The formation of intestinal fistulae is a severe complication of treating an open abdomen. Frequency ranges between 4 to 41%, and mortality is increased by 30 to 60%. The exact reason for occurrence of intestinal fistulae is not always apparent. Often it indicates the severity of the underlying disease. The prognosis depends on various factors. The origin of the fistula can be assigned to the small intestine or colon. Size and volume output are also of importance. Spontaneous closure of enteric fistulae can be expected in 30 to 70% of cases. Fistulae open out into an open abdomen are less likely to close spontaneously. The rate is as low as 6 to 37%. Whenever possible, a surgical closure of the fistulae should be attempted. In some cases, suturing might be sufficient. In other cases, extensive division of adhesions and resection of parts of the small intestine or colon is necessary. Other possibilities are the use of adhesives or coagulation activating agents. Unfortunately, sufficient closure of intestinal fistulae is not always achievable. Long-time treatment of an open abdomen or recurrent attempts of closing enteric fistulae might lead to formation of a frozen abdomen. This means a tight adhesion of intestines with the abdominal wall. Usually this results in extensive wound areas. Fistulae ending in these areas are called enteroatmospheric, in contrast to enterocutaneous fistulae open out into the skin. In most cases, a usual ostomy care is not feasible. Wound care is time-consuming and costly. Use of various catheters for drainage often leads to disappointing results.